All right, here we go for part 2 of the surgery EOR rapid review session. These are just your first order questions that will hopefully help you pick the right answer on the exams. So let's get started. What is the most appropriate IV fluid for a pre-op patient that is NPO? This is going to be lactated ringers. Sodium chloride is what normal saline is, and the excess chloride can actually lead to vasoconstriction, which we don't want in these pre-op patients. Lactated ringers has the lactic acid buffer, which actually does save the kidneys. So that's why lactated ringers is the better option here for someone who is NPO and doesn't have other electrolytes that are going on in the system, and we don't want to affect them. What is the preferred form of vascular access in a patient requiring long-term hemodialysis? So here we're going to go with an upper extremity AVF, so that fistula between the artery and the vein. It's the best thing if we're going with a repeated access thing with hemodialysis for long-term management. What is the Rancing criteria for acute pancreatitis? So I just think of Rancing criteria. I remember the mnemonic LEGAL. And so L for leukocytes, E for enzymes, specifically AST, G for glucose, A for age, and L for LDH. So here we're going leukocytes higher than 16,000, AST higher than 250, glucose higher than 200, age higher than 55, and LDH higher than 350. So just remember, Rancing criteria is used for acute pancreatitis to quantify how sick these patients are and their acuity level. What is going to be the root cause of Wernicke's encephalopathy? So it's really due to the thiamine deficiency. So make sure you replace thiamine before giving them glucose. And just real quick, I watched something long time ago to remember the B vitamins. So just remember when we're trying to term which B goes with which name, you want to go B123 skip 5, 6, 7, skip 9, 12. So no, there's no such thing as B4, and there's no such thing as B8. And then remembering them in order, you can use the mnemonic, then Ronaldo, nicknamed Pentaldo, played ball for Chester. That gives you TRN, skip PPB, skip FC. But thiamine, T, thiamine, B1. It's the issue in Wernicke's encephalopathy. If an endoscopic band ligation fails for a patient with esophageal varices, what's going to be the next step? We're going to move on to a balloon tamponade within about 24 hours to try to get that issue with the portal hypertension, the bleeding, all of that. Adding in this, the balloon can help push those vessels back and not have the extreme issue that esophageal varices has at that esophageal gastric level. Which antibiotic is going to be given for spontaneous bacterial peritonitis in a prophylactic setting? So prophylactically, you're going to be giving a beta blocker. What are the 3 drug options for a healthy patient with community-acquired pneumonia? So first, we have to decide, okay, patient is either healthy or not. If we think you're a regular person who developed community-acquired pneumonia, we're going to go through our MAD drugs. So outpatient, healthy person, pneumonia, we can either do a macrolide, usually a Zithro. We can do amoxicillin, which is the drug of choice, although resistant stuff, reasons why people don't always use it. And then if they can't do the amoxicillin, we'll then do the doxycycline if there's that allergy. And then if you get community-acquired pneumonia, it's just you're MAD. So use your MAD drugs for that. And then you can work it up. Use your CURB 65 if they have 2 of those. Now you're going to admit that patient. But your healthy patient, not going to be super crazy. Probably going to go with like a Zithro, amox or doxy for 5 days. So what is going to be the only drug for a patient with comorbidities that has community-acquired pneumonia? This is when we're going to go with fluoroquinolone. So your MAD, your MAD drugs, is just your person who's healthy who got sick and they're annoyed. They're mad, but we just think someone who got a comorbid, who has comorbidities, who got pneumonia, now we're thinking we need to add a fluoroquinolone for them. What is the platelet count threshold for a patient undergoing surgery? It's going to be 50,000. If we're lower than that, the chance of them bleeding is going to be too high. We can't do that surgery until we address why their platelets are so low. What is the diagnosis associated with increased fibrin degradation and schistocytes? This is going to be disseminated intravascular coagulation, DIC. I just think about DIC as basically the patient is bleeding from every area possible, nose, eyes, ports, everything. They're just used all of their clotting factors, and then now they have none, and so they're just going to bleed. So it's not uncommon for these patients to first be pretty hemodynamically stable, and then all of a sudden bleeding out of everywhere, can't coagulate, can't get a clot. What is going to be the most common cause of DIC? And that's either going to be your E. coli or other gram-negative infections. But E. coli is a big one. How does TXA work? What is the mechanism for TXA? So TXA works kind of at the end of the coagulation cascade. We know after you meet up with your common pathway, there's a factor 10, and then we get fibrinogen that gets converted into fibrin from thrombin, and then fibrin is essentially your clot. I think of it as like that. It's the glue. It helps cross-link all the clots together. And then from there, once you have your clot in place, plasminogen comes along and it acts on plasmin to degrade the fibrin clot. But what TXA does is actually stops the bleeding by stopping plasmin. And so it doesn't allow the clot to degrade. It keeps it there. What is the general approach to chronic constipation? So generally, we want to be conservative. So start with your bulk formers. Start with water and fiber. The best one would be like psyllium. It's literally just fiber. So that's like a good option. After that, if they're refractory, we can go on to our osmotic laxatives. You got to be careful with these. You can't use them long term, but they both increase the consistency and the frequency of the stool. Things like lactulose, PEG, or glycerin suppository stuff. Magnesium's also in there. And then, if that doesn't work, we can move on to a stool softener, something like docusate, which can decrease the surface tension of the stool to prevent straining. They're known as emollients. That's an option. And then if it's really bad, you can go to bisacodyl or senna, which is a stimulant laxative, which actually works on the nerves to cause bowel movement within about 8 hours. So this can cause cramping, electrolyte imbalances. This can actually cause extreme diarrhea. So be careful with that. Always start with your fiber and then kind of work up from there. But treating constipation is very difficult. What is pentolamine used for? So phentolamine is used for hypertension with a pheochromocytoma. So I think of PHEN, PHEO. Very close in names, phentolamine and pheochromocytoma. We're going to just see that PHE and think, okay, that's the treatment. Which medication class is given to a patient about to undergo surgery for a pheochromocytoma resection? So we're going to do an alpha blocker. We can either use doxazosine or phenoxybenzamine. Always remember your alpha receptors cause constriction, your betas cause dilation, A, B, C, D. Super common way to just remember this. So if we have someone going into surgery for a FEO, we want to give them an alpha blocker because we don't want that unopposed alpha adrenergic response, because that's kind of where they're already at. So start with that alpha blocker to kind of bring things back down to normal. What is the best treatment for a patient with hypovolemia and pulmonary edema? We're just going to go with a loop diuretic. Pretty straightforward. It makes sense. I have Vomethadine here, but you can definitely use like Lasix, furosemide, anything like that for hypovolemic states. Which condition has pretibial myxedema? So this is Graves' disease. Remember, Graves' disease is the hyperthyroid situation, but you can also have people that are in severe hypothyroid states go into a myxedema coma. So just don't get confused about that. If it's on the leg, it's from hyper. If they're in a coma and they're saying myxedema, then it's from Hashimoto or something similar that's causing too low. All right, which condition has loss of 1/3 of the outer eyebrow? And this is going to be hypothyroid situations. It makes sense. I mean, if we're thinking about endocrine, the underperformance of the metabolic system will decrease hair growth. And for some reason, it affects the eyebrow, and it's also known as Queen Anne sign. But I think incorrectly, historically, it's not associated. But Queen Anne sign, hypothyroidism, loss on the outer 1/3 of the eyebrow. So what will define severe ulcerative colitis and toxic megacolon? A couple things. They need to have more than 6 bouts of diarrhea in a day. Their inflammatory marker, their ESR, needs to be above 30. They need to have a low hematocrit, meaning that they're losing blood with this diarrhea. And then they need to be tachycardic and feverish, kind of that septic sign. And then remember on the dilation of the colon is going to be above 6 centimeters. Toxic 6. What diagnosis is associated with red blood cells in the CSF? So you did a lumbar puncture and you're noting blood in the draw. This is going to be from a subarachnoid hemorrhage, and it's associated, it's a way to diagnose a subarachnoid hemorrhage, and it's actually called xanthochromia, and that's telling you, hey, this is a subarachnoid state here. What site for a central line has the lowest risk of infection? So best choice is going to be the subclavian vein, and then we go to internal jugular vein, and then we go to femoral vein. Kind of makes sense. Subclavian vein, it's not too close, it's not too far. Internal jugular vein, obviously more direct. Femoral vein, you can still use it, just a little further away, more chance of infection there. What's going to be the difference between normal saline and lactated ringers? So similar to the other question, but it's really just the less chloride in the lactated ringers, and that can affect the acidotic state of the patient. Which electrolyte abnormality is associated with gastroenteritis and vomiting? So it's going to be hypokalemia. Might see this in even bulimic patients. Another electrolyte would be chloride for sure. But hypokalemia is kind of more worrisome. As we know, we get that T-wave depression, things like that. What is the most common cause of hospital-acquired pneumonia? It's going to be your gram-negatives, like Pseudomonas, E. coli, and Klebsiella. Just think about how the first aid sign typically has a plus, but no, if we're talking about pneumonia, it's a no sign, it's a stop sign, it's negatives. If an error occurs related to a surgery, what's going to be the best step for ethical disclosure? These ethics questions are kind of hard, but just know you have to go to the patient first before you're going to the hospital. What condition is going to have a 20 plus millimeters of mercury pressure difference between the right and the left arm? It's going to be an aortic dissection. All right, that is all for now. Don't forget to subscribe, like the video, comment, anything like that helps me grow this channel. And I'll see you guys in the next one.